Good morning. I'm Dr. Jidesh from the Department of Orthodontics to the Maya Institute of Dental Science, and I'll be discussing today about the Class 3 malocclusions. Coming to the introduction part, Class 3 malocclusion is often considered easy to identify but a difficult one to treat. It represents a prenormalcy when the mandibular arch is in a mesial relation to the maxillary arch. Class 3 malocclusion finds highest incidence in Japan and Korea. Coming to the definition, according to Edward H. Angle, Class 3 malocclusion can be defined as a condition where the mesiobuccal cusp of the upper first molar occludes between the mandibular first molar and the second molar. What are the features of Class 3 malocclusion? The molars will be in Class 3 relationship, angles Class 3 relationship. Incisors may be in an edge-to-edge relationship and an anterior crossbite may occur. Upper arch is frequently narrow, crowded, and short, while lower arch is broad. Vertical growers exhibiting an increase in the maxillary height may have the presence of an anterior open bite. You can see in the figure, and externally the patient will be having a concave profile. Most class 3 malocclusions are associated with underlying skeletal malrelationship. Commonly seen in skeletal features are a short or a retrognathic maxilla, or a long or a prognathic mandible, a combination of a retrognathic maxilla and a prognathic mandible. Coming to the etiology of class 3 malocclusion, one is the postural habits and mouth breathing. Habitual forward positioning of the mandible due to occlusal prematurities or enlarged adenoids. Severe class 3 malocclusions are believed to be caused due to genetic factors that have been made worse by environmental factors. Diagnostic. A diagnostic procedure should help in the determination of type of class 3 malocclusion, that is dental or skeletal 2 or 0 class 3 malocclusion. This is by clinical examination, which includes the observation of path of closure. Then study models and radiograms should also be taken. A lateral cephalograms offers a valuable information on the skeletal nature of the malocclusion. The patients with the class 3 malocclusion often have a family history of other people having an anterior crossbite or a class 3 malocclusion. Dental class 3 malocclusions are characterized by lack of sagittal discrepancy. The A and B angle is normal. The dental problem is caused by labial tipping of the mandibular incisors. Skeletal class 3 malocclusion patients exhibit smaller than normal SNA and a larger SNB angle, a negative A and B angle, maxillary incisor proclination and retroclination of the mandibular incisors. If patients with a pseudo class 3 malocclusion, a functional shift is seen. They show a COCR, that is central occlusion regulation shift as a result of abnormal tooth contact, causing a forward shift of the mandible on closure of the mandible. Treatment is class 3 malocclusion should be recognized and treated early due to the following reason. Early interception reduces the severity of the developing malocclusion, and class 3 malocclusion is characterized by anterior crossbite often result in retarded mandibular maxillary growth due to the locking of the maxilla within the mandible. The occlusal forces on the mandibular incisors exerted by the maxillary incisors in crossbite encourages the continued forward growth of the mandible, further worsening the prenormalcy. In class 3 malocclusion, the treatment is differs. Growing patients are now, if the growing patient and a non-growing patient, a growing patient, skeletal class 3 and dental class 3 will be there. And in skeletal class 3, the problem could be with the maxillary retrognathism. The treatment option is face mask to protect the maxilla. If the mandibular prognathism and maxillary retrognathism, face mask followed by chin cup, functional appliances for class 3. In mandibular prognathism, chin cup therapy to restrict the maxillary, restrict the mandibular growth. Dental class 3, orthodontic treatment as needed. In an ongoing patient, orthodontic treatment as needed, dental class 3 and skeletal class 3, mild to moderate class 3, Orthodontic camouflage by extraction of some teeth. Severe class 3 maxillary retrognathis, surgical maxillary advancement, and mandibular prognathism, surgical mandibular setback. Interception during the growth. Class 3 malocclusion with an underlying skeletal malrelationship requires early interception to prevent skeletal malocclusion. The aim of such treatment is to improve the skeletal discrepancy, thereby providing a favorable environment for future growth. It also helps to eliminate and reduce the chances of orthognathic surgeries in future. Indications: good facial aesthetics, presence of anterior posterior functional shift, mild skeletal problems, absence of familiar prognathism, convergent facial type, symmetric condylar growth, patients with the growth still present, cooperative patients. Contraindication: poor aesthetic, facial aesthetics, absence of anterior posterior functional shift, familiar prognathism, divergent facial type, severe skeletal problems, asymmetric condylar growth, patients with no growth potential, and cooperative patients. Interception during growth can be done by using one of the following techniques. One is myofunctional appliances, where you can use a Frankel's 3 appliance to intercept a class 3 malocclusion due to maxillary skeletal retrusion. And the treatment using the Frankel's 3 appliance is more successful in patients with a functional shift of the mandible during closure of the jaw. It can incorporate vestibular shields in upper and lower sulcus. The maxillary shields are placed away from the buccal plate, thereby stretching the periosteum and allowing the forward growth of the maxilla. The mandibular shields can be placed touching the alveolar process, thereby helping in restricting the mandibular growth. And Frankel's 3 appliance also produce a dentoalveolar effect by proclination of the upper anteriors and retroclination of the lower anteriors. Can also be used as a retainer after face mask therapy. Chin cup therapy is used for the treatment of class 3 malocclusion with protrusive mandible and normal maxilla. Two types are commonly used: occipital pull chin cup, vertical pull chin cup, used in patients who exhibit a steep mandibular plane angle and excessive anterior facial height. Effects of chin cup includes backward reposition of the mandible, redirection of the mandibular growth, remodeling of the mandible with closure of the conial angle. Chin cups with headgears are indicated in primary and mixed dentition. Force levels of 300 to 500 grams per side is indicated for 12 to 14 hours of wear every day. Face mask, also known as reverse pull headgears, used in the treatment of mild to moderate skeletal class 3 malocclusion due to retrogradic maxilla and hypodivergent mandible, consist of two pads that take anchorage from the forehead and the chin. They are connected together by a midline wire frame that also has hooks and that help in anchoring the elastics that stretch from the intraoral splint, which helps in the protraction of the maxilla. The intraoral splint can be included as expansion screw if the expansion of the maxillary arch is required. Protraction face mask is used for the primary and mixed dentition periods. Force levels 300 to 500 grams per side as indicated. 12 to 4 hours of wear every day. Commonly used types are Delia type, the Tobinga type, and the Petit type face masks. Now coming to the treatment using with the fixed appliance, best done in mixed dentition before the eruption of the permanent canines. In patients with a mild to moderate class 3 skeletal pattern, a combination of retroclination of the lower incisors and proclination of the upper incisors may be required. So, class 3 intermaxillary elastic traction from the lower labial segment to the upper molar can be used to move the upper arch forward, the lower arch backward. However, care is required to avoid extrusion of the molars, which will reduce the bite. Treatment of anterior crossbite. Mild anterior crossbite can be treated using lower anterior inclined planes or removal appliance incorporated screws for the anterior expansion. And for posterior crossbite, you can use with the rapid maxillary expansion. Role of extraction. Class 3 malocclusion characterized by mild mandibular prognathism and lower arch crowding can be treated by extracting the lower first premolar followed by the fixed mechanotherapy. This is termed as orthodontic camouflage for the underlying skeletal class 3 malocclusion. Severe class 3 malocclusion treatment includes Uh, After completion of the growth, it's treated by surgical and corrective procedure. And class 3, due to maxillary deficiency, treated by maxillary advancement procedure called a Leaford 1 osteotomy. Class 3 malocclusion as a result of mandibular prognathism can be treated by mandibular setback procedures. Pseudo class 3 malocclusion. Pseudo class 3 malocclusion occurs due to occlusal prematurity. Hence, removal of the cause leads to the correction.